Hi, this is Rebecca Hergert. Today we're going to talk about how to assess an IV site. First thing you need to think about is, when do you need to assess an IV site? You need to assess an IV site beginning of every shift, anytime you're going to use it. If the patient begins to complain of any pain, burning, discomfort, irritation, if they're confused, if you see them just start touching it, messing with it, trying to pull it off, you need to check and see what's going on with the site. And also at the end of your shift to make sure that you're not leaving somebody a bad site. When you look at a site, the things that you're going to look for is what gauge of needles in the site. What's the dressing look like? Is it clean, dry, and intact? Is it starting to pull up at the edges? Is there fluid underneath it? What about the IV site itself? Is there any redness, any swelling? Is there any pain? Is there any leaking? Is it warm to touch? What about above it? What about below it? Is the hand warm? Is it cold? Or whatever the body site is. What's the temperature of the surrounding skin? You need to look and see when it was inserted, because they're only good for so long. After 72 to 96 hours, you have to change them. So anytime you look at your IV site, you need to look and see when it was inserted. Don't necessarily go by the chart, because if somebody forgot to enter it, if somebody didn't document on it well, you may have two different things between what's in the chart and what's on the site. So your site really should be labeled. What is connected to it? Is there anything connected to it? Is it just what they call an INT, an intermittent saline lock? Or is there tubing attached to it? Is there fluids attached to it? Is there any kinks? Is it running okay? If the machine's beeping a lot, you might want to look at your site. Look and see why the machine says it's beeping. Look at your site. Make sure that it's not occluded, because that's another problem. If the IV fluid's not running, and if you don't have it on a pump, you really have to watch it. You really have to watch the bag. You really have to watch the site, because it's not going to warn you if the site's occluded. You're just going to have to catch it by looking at it. You should flush your IV. If there's not fluid running at the beginning of your shift, you should flush your IV and make sure that it flushes. If it flushes well, there's no pain, there's no swelling, your site's probably still okay. If you go to flush it and it won't flush, don't force it. One, make sure the clamp's unclamped, because I have a friend who changed an IV because she forgot to unclamp the clamp. She thought it was occluded. No, gotta unclamp the clamp. There's a little clamp on the tubing, and I'm going to show that to you. If that tubing, if that is clamped, you're not going to be able to flush it. But if that's open and you can't flush it, probably means there's a clot at the end of that. And you don't want to force that clot off, right? Because that clot could go anywhere. It can go to their kidneys, it can go to their brain, it can go to their heart. We're not trying to give anybody a stroke or a heart attack over a IV, right? So just don't do that. But as long as it flushes well, patient's not complaining of any pain, there's no swelling at the site when you push the fluid in, your site's probably still good, you can keep it. When you look at the site, it should say on the dressing what gauge it is. If it doesn't, sometimes you can tell by the color of it. But, man, I'd hate for a manufacturer to change the colors of their IVs hubs somewhere between when I'm talking to you now and when you go to assess a site and you not get it right. So kind of look and see what the colors are at the facility where you're working for the type of needle that's in that patient, so you can make sure that you know what gauge it is. So what gauge should it be? If they're under a year old, you're going to look for a very small gauge. And remember, the smaller the gauge is, the number larger or smaller? Right. Smaller the gauge is, larger the number is. So if for an infant, somebody under a year old, you're looking for a 24 gauge, maybe 22 gauge, but you want those very small gauge needles, because guess what? They've got tiny little veins. Whenever you're looking at someone that's from a child, 1 to 8 years old, you're still looking for 22, maybe a 20. Depending on where it's at, you might get an 18 in there. For an adult, they usually prefer the larger gauges. They want a 16, 18, 20. If you could get them, if the person putting them in is able to do that. Now, sometimes it depends on the condition of the patient's veins, the location that they're able to find. Sometimes you have to go in veins that just don't allow that size needle. So you have to you'll get into that whenever we talk about putting in an IV we'll talk about that more in depth. What you need to know is you need to document what gauge needle you took out. And you have to know what gauge needle's in there. The larger your gauge, the smaller your needle, the slower you're going to have to run things through it. The smaller number on your gauge, the bigger your catheter is, you're going to be able to run things through it more swiftly, and sometimes more things. When you look at that site, you need to look at how long it's been there, because you really do want to change them every 72 to 96 hours. Why do you want to do that? Because if it stays too long, it becomes more a possibility for infection. Anything that stays too long just does that. Anything sits out. Whenever someone comes in from an outlying situation, they come in on the ambulance or something, you usually want to change that within 24 hours, because sometimes they have to put those in really quick, and maybe they weren't able to do it as cleanly as you would have liked. So you don't want to leave that in there too long, give any bacteria that's there a chance to really grow. Okay, you kind of want to change those out as soon as you can. If it's somebody that's really dehydrated and you really have to give them some fluid first to fill up their veins enough for you to be able to find them, you may need to let it run for a while. So don't rip them out first. Never stop an IV, take out an IV that's working until you have a new one in. Because if you can't get a new one in and you just took out the one that was good, you've just disabled the patient's ability to get their medications or their fluid or whatever it is they need. So don't take them out until you get the next one in, then go back and take that one out, unless it's bad. We're going to talk about what bad means. While you're looking at the dressing, also remember to look at the tubing in the bag, because everything should be labeled. Everything should have the date and the time, either when it was hung or when it's going to be changed, and your facility will dictate how you're going to label it so that everything's consistent. So I'm not going to tell you how to do that. You're going to look to the facility policy where you work as far as how they determine that that needs to be done. But it should be labeled and timed and dated in some manner. That way you know when you need to change tubing. You can't leave the tubing up forever either, and depends on what's running through it, how often you have to change it sometimes. You can't leave a bag up for more than 24 hours. I don't care what it is. You can't leave it up for more than 24 hours. It's going to grow bacteria, and it's going to cause problems for your patients. So if they're only getting like 30 or 50 milliliters an hour and it's a 1,000 milliliter bag, are you going to be able to leave it up there 24 hours? Well, multiplication says no. So you can't always just wait until the bag empties out. You need to know when that bag was hung. Make sure that you take it down at the right time. So what should it look like? The dressing should be date timed, and it shouldn't be past that date and time. 3 days, 4 days, however long, 72, 96 hours, it shouldn't be past that time. If they're going to be discharged, some facilities allow you, if they're going to be like discharged that next day or later on today, some of them don't make you change it when you're just going to pull it right back out. Know what's happening with your patient. The dressing should be clean, dry, intact. There should be no warmth, no redness, no swelling. That's what it should look like. That's the ideal. So who's most likely to wind up with problems? Same culprits. People that are immunocompromised, the elderly, and the very young. These are always people that we have to be especially careful with, because they're more at risk for complications for just about everything. And that includes infections from the IV site or swelling at the IV site. They're more at risk for infiltration, and that's when the fluid gets outside of the vein. Sometimes some things that we give people is a little caustic to the vein. It's got a lot of potassium in it, or it's got a lot of sodium in it, or the medication that we're given is relatively caustic, and sometimes it can make a hole in the vein. So if it makes a hole in the vein, it can begin to leak out. If they move around, jerk around a lot, they can actually wind up working the tip of the catheter out, and now it's just laying beside the vein instead of in the vein, and it can infiltrate. The other thing that can happen is phlebitis, and that's when you get an infection in the vein. So we're going to talk about how those look, how you can tell which one it is. If a person has hypertonic medications that have a lot more solute in them than the plasma, if the medications is acidic or irritating, chemotherapy, Phenergan, these medications are just known for tearing up veins. Potassium Depending on how much potassium you have in your bag, sometimes you can't even use the peripheral site. You have to use a central line where the vein is bigger and it's not going to come into as much contact with the wall. It's just going to like shoot down because of the rapidity of the blood flow in that area. If they've got fragile veins, as we age, we begin to lose skin cells, and that includes the veins. People who have diseases that affect the intima, the inner lining of the veins, will sometimes, their veins will just break down and they'll infiltrate. If your IV is infiltrated or if it has phlebitis, you need to discontinue the IV. You just need to take it out and apply a warm compress over the area. Nice, moist, warm. Usually what I do is I take a rag, I put it under the sink and run the water as hot as I can take it, because I don't want to burn them. If I can take it, it's probably not going to burn them. So, and then I wring it out really well. By the time I get it over the patient, it's cooled down just a little bit more even, so it's not as comfortable for them. And I always touch it to them first and ask them if it's okay. If they say no, it's too hot, then I wait a couple more minutes and put it on, because I'm not trying to burn people.